Hi everyone, my name is KellyDuong. I will be briefly presenting my clinical track Capstone medication use evaluation on antipseudomonal antibiotics, Piperacillin-Tazobactam, Cefepime, and Meropenem. The MUE was prompted by an increase in antipseudomonal antibiotic usage over the past year with a surge in early 2021 at the Community Hospital Adventist Health Portland, located in Oregon. This was my API site for blocks 1 through 4. I was here for 6 months. This quality improvement project was in collaboration with Kirsten Walskog, the clinical coordinator, who was instrumental in guiding me in planning and conducting this MUE. So our project or our study objective was to characterize the use of parenteral anti-pseudomonal antibiotic across all areas of our hospital and to identify internal process improvement opportunities for antimicrobial stewardship efforts. This was a retrospective chart review. We evaluated patients admitted to Adventist Health who received an IV anti-pseudomonal antibiotic course during their admission. So a 6-month period was between December 1st, 2020 to June 1st, 2021 was audited. To identify patients and collect preliminary data, we used a proprietary clinical surveillance program, Vigilance, that was integrated with our EHR. 843 patients with a Zosyn, Cefepime, or Meropenem order over that 6-month period were initially identified. And then using a random number generator, 10% of the larger cohort were randomly selected for extensive chart review. And then of the random sample of 85 patients, ultimately only 61 patients were included in the MUE after exclusion criteria were applied. Reasons for exclusion of the 24 patients included if they were not admitted, if they were transferred to an outside hospital from the ED, or if they only received 1 dose of antipseudomonal antibiotics. The primary outcomes were to evaluate the appropriateness of antibiotic selection and duration compared to our institutional inpatient empiric antibiotic selection guidelines, which are based off IDSA guidelines. And then the secondary outcomes were to describe the percentage of patients with culture-proven Pseudomonas, average time to antibiotic de-escalation, C. diff infection rates, evaluation of multi-drug resistant organism risk factors, and Pseudomonas and MRSA risk factors independently associated with the presence of resistant pathogens. So the characteristics of the audited patients included an average age of 63, 44% of them were female, 67% received Zosyn, and then the remaining 33% equally received Cefepime or Meropenem. So the top 3 indications for antibiotic usage was sepsis, UTI, and pneumonia. 66% of the patients had an infection-related diagnosis on admission, while 1/3 of them actually, the patients were admitted without any infection-related diagnosis. So non-infection-related diagnosis included conditions like cardiac arrest, STEMI, and overdose. So we're looking at those patients that got antibiotics without an infection-related diagnosis. So now on to the results. For primary outcomes, the MUE revealed that 64% of the time, appropriate selection of empiric antibiotics occurred. So the most common reason why it was deemed inappropriate was that ceftriaxone should have been chosen instead of an anti-pseudomonal drug. So anti-pseudomonal coverage was not necessary based on the patient's risk factors. For example, if the patient was recently hospitalized and received antibiotics within the last 90 days, but the patient was transferred to the floor and not the ICU, and they did not meet at least 3 criteria for what IDSA defined as severe pneumonia, then they shouldn't have been started. They should have been started on ceftriaxone and azithromycin and not Zosyn, which was a common occurrence. And then the duration of therapy was found to be appropriate 89% of the time of the cases, so that's good. And then the patient who received a duration of total antibiotics longer than recommended, the mean duration was 2.3 days longer than indicated. So for the secondary outcomes of the 61 patients with anti-pseudomonal coverage, only 12% of them ended up having a positive Pseudomonas culture, and then average time to de-escalation was 18.1 hours there. And then 1 patient developed C. diff, And then in patients with at least one MDRO risk factor, 24% of them consequentially resulted in a positive MDRO culture. And then of the 32 patients with Pseudomonas or MRSA risk factors, only 6 resulted in a positive culture, of a positive Pseudomonas or MRSA culture. So for our MUE findings and future directions, we identified that patient care can be improved if we as healthcare providers focus on screening initial orders against validated risk factors and using our institutional guidelines consistently. We should consider the patient and their risk factors and what they really need before putting orders in or verifying therapy. Should be a focus of staff re-education. In an effort to minimize patient harm and exposure to unnecessary antibiotics and to reduce the development of antimicrobial resistance, pharmacists can take accountability to employ antibiotic stewardship best practices every day, including guiding them or guiding the team to choose the correct drug, correct dose, correct timing, and correct duration of anti-infective therapy. And that concludes my Capstone research project. Thank you for joining in on our PUSOP 2022 Research Symposium. I would also like to acknowledge Dr. Chris Marcus, my Capstone mentor, for her help and support throughout this project. She's been super helpful throughout the year. Then my contact information is on the bottom right here if you have any questions. Thank you.